I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's virtual events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's virtual events series.
Good afternoon, and welcome to the continuation of the Benjamin Rush Institute's live event series. My name is Rebecca Kiesling, and I am BRI's Director of Programs. I see a number of people that have been here through all of our live event series. We have done a number of these since March when the coronavirus pandemic began and shut down medical schools across the country and internationally. We pretty seamlessly shifted to an online-only event, which is different than having our events in medical schools, because we have been streaming our events throughout campuses for a couple of years now. So shifting our events to only online was pretty easy for us. And we are so thankful to all of our speakers that we've had since March. And we're excited that we will be continuing these since so many of the medical schools are having a mostly online component now that they've come back into session. If you want to see any of our series, you can visit our website at benjaminrushinstitute.org. Today, we're really excited to be talking about certificate of need. A shortage of healthcare facilities can prevent patients from getting the care that they need. But when these shortages occur, which we've seen throughout this pandemic, logic will say just build new facilities. In many states, it's just not that easy. And certificate of need laws or con laws are to blame. Even the American Medical Association advocates for a repeal of con laws. They call these con laws failed public policy. While they are designed to control costs, state certificate of need laws do the exact opposite. We're excited to welcome today our guest, Matthew Mitchell. Matt is the Senior Research Fellow and Director of the Equity Initiative at our good friends, the Mercatus Center at the George Mason University. He's also an adjunct professor of economics at Mason. In his writing and research, he specializes in public choice economics and the economics of government favoritism towards particular businesses, industries, and occupations. Matt has testified before the U.S. Congress and has advised several state and local government policymakers on fiscal and regulatory policy. You can find his research in numerous national media and other outlets. He blogs about economics and economic policy at The Neighborhood Effects and at Concentrated Benefits. We are streaming live on Facebook and on Twitter and here on Zoom. So if you have any questions, please use the chat features or the Q&A feature, and I will be taking those questions, and Matt will be answering them later on. I'm really excited to have Matt Mitchell today. If you heard Dr. Darcy Bryan just a few weeks ago, she lauded his expertise. So please ask any questions that you have, and I'm going to let Matt take it away.
Thank you for that very kind introduction. I'm excited to have the opportunity to chat with you all today. This is a topic that is near and dear to my heart, in part because it's the kind of regulation that when you first hear about it, you think this can't really be a thing, right? It almost sounds like a made-up story, but it is actually true, and it's pretty remarkable how these things work. So I'm going to share my screen here and give you a bit of an overview of what we know about how these rules work. Okay, so first of all, what in the world is a certificate of need law? Well, probably the best way to think about it is that it is a permission slip to compete. Unlike other types of permission slips like occupational licensing rules, however, it does not even pretend to be any sort of quality gate. If you want to enter or expand your healthcare facility, you want to build a new hospital or a neonatal intensive care unit, maybe even add a few hospital beds, you need to ask for permission from the regulator to do so. And in the process of evaluating your ability to enter that industry, they are not going to evaluate or inquire as to your safety record or your qualifications or the cleanliness of your facilities or anything like that. Instead, their main goal is to see whether or not your community actually needs the service in question. They're going to second guess that. And in doing so, they will not only is it possible that the regulator themselves will be comprised of a board that might have your competitors, but even if they don't have your competitors on the board, they will seek out your competitors, and your competitors are able to go before the board and protest your entrance. So sometimes they're called they're called competitor veto laws because they give an extraordinary amount of power to those who are already in the industry to veto the entrance of a competitor. So if you want to think about it in terms of another industry, this would be like, your local pizza shop being able to stop the entrance of a new pizza shop coming into town. So as far as economists are concerned, of course, one of the things that's notable about this is that this is a really unusual type of law in a market-oriented economy. It tends to be modeled as a restriction on supply that limits the supply of the service, and we tend to view them as an anti-competitive measure. I should note that economists are not unique in considering these rules to be anti-competitive. As already noted, doctors themselves view them as anti-competitive. The American Medical Association has taken that position, but so have antitrust authorities in the Federal Trade Commission and the Federal Department of Justice under both Republican and Democratic leadership have for several decades now regarded these rules as anti-competitive. So where in the world did they come from? Well, they started in New York in 1964, but they really got a big boost in 1974 with the passage at the federal level of the National Health Planning and Resources Development Act. And that act withheld federal funds from states that did not adopt con laws. And in the act, it's interesting, they actually state quite openly in the first few pages of that act the goals here. So they said that they wanted to ensure an adequate supply of healthcare, particularly in rural communities. They wanted to promote high quality care. They wanted to promote charity care. They wanted to encourage hospital substitutes, and they wanted to restrain the cost of care. So what we and others have done is used this list, which is often continues to be touted as the goals of con laws by con law advocates and by the con boards themselves. We've used this as essentially a guide to our research. So we have, for the rest of the talk, I'm going to use this list essentially to kind of organize the discussion. So incentives work. In 1974, when Congress passed the act, about half the states had con laws. By 1980, everybody but Louisiana had a con law. Louisiana has a bit of a history of bucking the trends whenever the federal government offers mandates that the states do things like, for example, raise the drinking age, or else they'll withhold federal funds. Louisiana can often be counted on to not go along. By 1990, however, the federal government around, I think it was 86 or 87, abandoned its requirement. And so then several states began easing or removing their con laws. Ironically, Louisiana at that point actually adopted a con law. Most recently, New Hampshire eliminated their program a few years ago, but other states like Florida have done quite a bit to eliminate particular types of cons and ease the program, the restrictiveness of the program. So we'll get into that a little bit more towards the end of the talk. Okay, so what kind of things are covered? Well, everything from neonatal intensive care units to burn care units to hospital beds, open heart surgery, organ transplants, hospice care, to nursing home beds and medical offices. It varies from state to state. Some states require a con for only a few of these types of products or services. Others require cons for up to 30 types of services. So let's return to this list and tick through it and see what the evidence shows. One thing to point out, by the way, is if you go back to those maps, or you think about those maps, at this point, we have 37 states that have con laws, another 13 that don't. It depends on how you count certain types of rules as a con law. But the gist of it is about 38% of Americans happen to live in a state without a con law. So this includes urban, rural, coastal, intercontinental, high income, low income, all sorts of mixes of populations. And we can look at the experience of people who happen to live in con states versus non-con states and compare them. And we can even control for all kinds of demographic and socioeconomic factors that might also affect these outcomes. And so everything I'm going to show you here, all the data is drawn from real-world experience. I want to highlight that because when you talk to legislators, they get very nervous about it. They've been told by hospital associations or others that, if you got rid of these things, we just don't know what would happen. Well, the truth is we have a very good idea what would happen because almost half of Americans actually live without these laws, and we can look at what's going on in those states. Okay, so I mentioned the economics of a con law. To just tax your memory and go back to Econ 101, demand curves slope downward, supply curves slope upward. They typically meet at an equilibrium, and that determines the quantity and the price. But what happens if you restrict supply? Well, the supply curve shifts left, and you would expect there to be a lower quantity of products or services. So it's really pretty remarkable that Congress actually thought that by restricting supply, they could increase the quantity supplied. There's really no reason in economics to believe that that would happen. And in fact, that's what the data show. It did not happen. So numerous studies over the years, and this is by far the most studied aspect of con laws, find that indeed they are associated with a lower quantity supplied of services. So in states with con laws, there are fewer dialysis clinics, there's fewer hospice care facilities, there are fewer hospitals per capita, fewer hospital beds per capita, fewer hospitals offering MRIs, fewer MRI, CT, and PET scans. There's more out-of-county MRI, CT, and PET scans. Patients have to drive longer distances to obtain care, and they're more likely to leave their state or their county in search of care. One thing that's interesting is what we have done at the Mercatus Center is we've taken the states that have con laws and we've extrapolated the data from these cross-state comparisons, and we can actually give you an idea of what's happening in specific states like Michigan. So for the rest of the talk, I'm going to just use Michigan as an example to kind of show you exactly what the effect of these con laws have been in that state. So currently there are 171 hospitals in Michigan. It's our estimate, based on the experience of other states, that a Michigan without con laws would have 243 hospitals. Were it not to have a con law. This is particularly important in light of COVID. So on the left, you see these are the states that require a con for a hospital bed. And on the right, those are the states that are projected to experience a shortage of ICU beds during COVID. As you can see, there's some bit of overlap. We gathered data on the states and ran some regressions controlling for other factors to see, okay, what is the statistical significance of that overlap? And this is what we found. So just to kind of orient you here, on the left side of your screen, that's the estimated percentage of states expecting a shortage in ICU beds. And on the right-hand side, all of this is the expected number of shortages. But on the left-hand side, that's among states that do not require a con for hospital beds. And on the right-hand side, it's among states that do require a con. There's 3 different estimates for each of those populations. Those represent the lower bound, the mean estimate, and then the upper bound estimate. So I'm just going to concentrate on the mean estimates. But among states that do not require a con for a hospital bed, about 13% of them are expected to experience a shortage in ICU beds over the course of the pandemic. But 30% of states that do require a con are expecting a shortage of ICU beds. So more than twice as many con states are expecting a shortage relative to non-con states. To put this in another term, what's the actual shortage in beds? Well, the shortage over the course of the entire pandemic among non-con states is only a shortage of 114 ICU beds. But among con states, it's over 8,000 ICU beds. And then finally, to put that in perspective of population, the shortage in terms of 10,000 persons, we're only expecting a shortage among non-con states of less than a single bed, 0.55 beds. But among con states, it's more than it's about 18 times that. It's 9.2 beds. So it's a pretty significant difference, right? All right, so what are the reality of con laws? Well, another way to think about it is in terms of access to rural access to care. So here again, think again about that supply and demand diagram, except now on the horizontal axis, instead of quantity of care, we talk about quantity of rural care. Well, again, the economic theory suggests that we're not going to have as much care, and sure enough, that's what we find. So there, not only are there fewer hospitals in con states relative to non-con states, there's fewer rural hospitals. There's also less access to rural hospice care, as I mentioned earlier, longer travel distances to care, and more out-of-state care in con states relative to non-con states. To put it in terms of a specific state with Michigan, there are currently 58 rural Michigan hospitals. It's estimated that absent con laws, there would be 83. So let's look at another goal, the goal of promoting high quality care. Here, the theory is a little bit ambiguous. It is possible, and this is the story that con advocates tell, that if you have fewer hospitals, more procedures will be channeled through those hospitals that exist, and therefore the physicians and other providers in those hospitals will get better at what they do. So basically, it's kind of a scale competency type of idea. Now, I would point out that this could potentially come at the expense of people having access to care, but it is a theoretically plausible story. The problem is that there's also another theoretically plausible story, which is that competition itself tends to increase the quality of products and services. This is no less true in healthcare settings than it is in other types of settings. So you have these basically two theoretically reasonable stories pitted against one another, and you have to turn to the data to see what's actually happening. So early on, there were some mixed results. There were about as many studies that they tended to focus on specific types of procedures, and they tended to have a hard time controlling for other factors. As it turns out, they were basically offered kind of mixed results. About half of the studies found that con laws were associated with higher quality care. Others found them associated with lower quality care. More recently, however, economists have exploited some pretty cool techniques actually to control for unobservable factors. So one of the things that they've been doing, for example, is looking at communities that happen to straddle a con and a non-con state. And this is nice because in that kind of a study, you can actually control for not only observable factors, demographics and otherwise, but also unobservable factors, things that you can't control for like the culture or the the underlying health character, some underlying health patterns of the population. And what those studies find is some of them find either no effect on mortality, that was Bailey in 2016, or more recently, when they look at zero and unspecific figures on specific types of sources of mortality, they will find actually, if anything, con laws are associated with higher mortality rates following heart attack, pneumonia, and heart failure. Also higher rates of post-surgery complications and lower levels of patient satisfaction. So again, turning to Michigan, let's look at what this means. The numbers are not huge differences, though they are statistically significant. But as you can see, there's the white is the current rate of heart attack, heart failure, and pneumonia in Michigan, and the blue is the estimated rate of heart attack, heart failure, and pneumonia absent con laws. There it is in terms of estimated readmissions following heart attack and heart failure. And these numbers are a little bit larger. The estimated change in patient satisfaction in Michigan without con laws is about 4.5. So this is basically, if you look at patients and you ask them to rate how they would rate their hospital experience on a 1 to 10 scale, this is the percentage of patients that would rate it a 9 or a 10 out of 10. And the estimated change in post-surgery complications is estimated to go down in Michigan without con laws. So the balance of evidence suggests that con laws do not promote quality care. What about charity care? Here, there's just simply no evidence of higher rates of charity care, but there is, however, evidence of greater racial disparity in the provision of care. This is from a study that looked at racial disparities between African Americans and other populations in terms of care. What about the idea of encouraging hospital substitutes? One of the goals of the National Health Planning and Resources Development Act was specifically to encourage hospital substitutes like ambulatory surgery centers. That's somewhat ironic now, given that about 28 states specifically have a con for ambulatory surgery centers. And what you find is ambulatory surgery center specific con states have 14% fewer ambulatory surgery centers per capita. They also have fewer rural ambulatory surgery centers per capita. And what we find is that con laws tend to limit the introduction of new hospitals and non-hospital providers, but they actually tend to have very little effect on existing hospitals in terms of their capacity. That's important because that helps explain why in the world existing hospitals like these laws, because they frankly have a better ability to navigate them and obtain their own cons while their competitors do not. So this is an estimate of the number of ambulatory surgery centers in Michigan absent a con law. What about the idea of restraining the cost of care? Here again, I'll tax your memories and go back to Econ 101, supply and demand. Here I want to emphasize that at the equilibrium determines the price. Well, what would we think would happen if we restrain supply? Basic economic theory suggests that price will go up. Even if demand is flat, price is certainly not going to go down. So it's weird to believe that con laws, a supply restriction like a con law, would actually reduce costs. I took a deep dive into this a few years ago, reviewed 20 peer-reviewed academic studies, and found the con laws work exactly as economic theory predicts. They don't achieve their stated goal of cost reduction. They're associated with higher per unit costs. So that's something like the cost of a well child checkup or a hip replacement or some other type of procedure. And they are also associated with higher total expenditures. So that's as measured by cost, the total amount spent per patient or the total amount spent per person in a state. So we can put this in terms of how much we think costs will change absent con laws. And again, this is drawn from comparing the experience of states that have con laws with those that don't. And the estimated change in annual per capita healthcare spending in Michigan without con would be a reduction of about $215 per person. So what are the options? Well, I would suggest that there are 4 varieties of reform. So first of all, there is outright repeal. This could take the path that states like Arizona and New Mexico and other states that repealed con laws right away once the federal mandate went away. It could also be a delayed repeal. New Hampshire did this in their most recent con reform. I think it was passed in 2015, but it didn't take effect for 4 years. So it gives providers some time to plan for it. You could also do a phased-in repeal. The idea here would be that the state legislature could require the regulator to approve a certain percentage of applications this year, say 60%, and then next year 70%, and just keep increasing that number until they have to approve all applications and basically shut down the con operation. You could also repeal contingent on the actions of others. So interestingly, a few of the states that repealed in 1987 right away, they did so, they had on the statutes laws that said in the event that the federal mandate goes away, we will repeal our con law. So you could do that today where you said, if the states surrounding us repeal their con laws, we'll repeal ours. That might give legislators a little bit of an easier time standing up to special interests. And then finally, you could do specific repeal of particular types of con laws. This is the path that Florida recently took. West Virginia also took this path. I would say that particularly ripe types of reforms are those that limit the supply of care to particularly vulnerable populations. So a number of states regulate the provision of psychiatric services or drug rehabilitation services, neonatal intensive care units, transplants, nursing home beds, ambulatory surgery centers. All of these things would be good candidates for specific repeal. Well, another variety of reform would be administrative relief. States could reduce the fees that are required to obtain a con. Often those fees are small compared to the regulatory, just the administrative burden of dealing with these laws. It's estimated that some providers have spent hundreds of thousands of dollars in years obtaining a con law. So reducing the administrative burden is another possibility. And then finally, another possibility is if an incumbent unsuccessfully challenges the application of a competitor, perhaps they could pay the competitor's legal and compliance fees. Another possibility is to change the criteria. So in many states, there is a duplication of services requirement, which basically says that a con is going to be denied if the new service duplicates an existing service. Well, what the regulators call duplication, economists call competition. And so this essentially ensures a local monopoly. So eliminating this language and asking con regulators to no longer use that as a requirement as a criteria could go a long way towards making these more competitive. They could also eliminate utilization criteria. So often regulators will look at a community and see, well, how many hospital beds are currently being used? And if it's under a certain percent, then they will deny a new application. There's a couple of problems with this. One of them is that it actually encourages perverse behavior. So if you're an existing hospital and you know your competitor might be denied their con application, if you do not have many of your beds filled, that gives you an incentive to not only not put patients in beds when they might need them, but also to acquire as many beds as you can over the long run, which is exactly the opposite of what cons laws were supposed to stop. The other problem is that patients themselves may know this. So if you are a mother going into premature labor, you've probably done a little bit of research and you know if your local community hospital doesn't have a neonatal intensive care unit. So you're not even going to stop there. You're going to go further down the road to the nearest place that does have a intensive care unit. And therefore, you're not going to show up in the statistics as asking for a bed and therefore needing it. Another possibility is to raise the monetary threshold. So sometimes a con is required for a very small investment of 20, 50,000, something like that. Raising it to several millions of dollars of investments will at least mean that fewer types of changes will be subject to con laws. And then finally, require input from uninterested parties. Rather than bring competitors in on the process of deciding whether they get to have competition, why not ask economists or antitrust authorities or people who have studied this from a uninterested position what they think about it. And then the final type of reform would be to require certain levels of transparency. So the legislators could actually enlist the con regulators in doing this. They could ask the con regulators to regularly report their approval rate. They could regularly report the rate of applications that are opposed by incumbent providers, and of course cross-tab that with the approval rate. They could require them to disclose applicant and opponent PAC contributions. There's research suggesting that that hospitals that contribute to PACs are much more likely to have their cons approved. You could ask them to report applicants' compliance costs. So as part of it, they could say, hey, if you're asking for a con, will you tell us how much time and effort went into this application? As I said, some providers have spent years and hundreds of thousands of dollars. Getting that information out into the public will help show really what a burden this is. And then they could follow up with denied applicants after a year or so to see what their experience has been. They can't this sort of would put a highlight on them on the past decisions to really make sure that they've worked as the regulators think that they ought to. So that concludes my presentation. I'm happy to take questions, look forward to taking questions. Thank you so much for the opportunity to chat with you all today.
So thank you very much. That was an incredible amount of really great information in 30 minutes. I learned a lot, and I've been following your work for a number of years. So I'm sure that our attendees have been following along as well. Something that this is one of my questions as well. Competition tends to evaluate quality, and you talked about this a little bit. What about things like how has this affected the rise of things like direct primary care, surgical centers, pay for services? Can you talk about that a little bit?
Yeah, so I guess there's two aspects of the research that kind of highlights this. One of them is the finding that existing large hospitals are typically not affected by con laws too much. They find it much easier to obtain their cons. And the reason for this is that there are large fixed costs associated with complying with any type of regulation. Anybody who runs a small business understands this. Once you hire one or two regulatory compliance officers, the costs per complying with more burdensome regulations actually, they're easier. So this is why small businesses find regulations really, really difficult. Frankly, a large hospital system is going to have a team of lawyers who can specialize in this. They can afford, by the way, there's private consulting firms that the hospitals often turn to help obtain cons. They can afford to pay those. So the smaller operators just can't do that. And so that's why we find that large operators seem unaffected. New hospitals and hospital alternatives are much more likely to be limited. And then the other aspect is just on the ambulatory surgery center specific cons is, a lot of those categories that you're talking about are regulators can consider them ambulatory surgery centers. And so they, if there's an ambulatory surgery center specific con, they're going to be limited.
Right. We have some international attendees here. Are there anything like con laws in other countries or neighboring countries?
Boy, that's a great question. I do not know. I haven't studied the international experience. I would presume yes. This, if anything, to me, studying it from an economic perspective and in comparing it with other types of systems, this seems like more of a command and control type of regulation that you would expect to find in a country that is, less inclined to characterize itself as a free market.
Right.
So, but I really honestly don't know. I'm not sure.
I live in Virginia. Always, con laws is something that's been brought up a number of times here in Virginia. How has COVID impacted con laws?
So about 25 states have eased or suspended their con laws in some way to deal with COVID. Some of these are kind of minor regulations where they just have said, essentially the executive has maybe directed the regulators to just go easy on it and be more inclined to accept applications. Others have been a little bit more significant. When we did our study of expected ICU bed shortages and con regulation, we also looked at the states at that point that had eased or suspended these rules. And unfortunately, we found no statistically significant effect. States that had gotten rid of their con laws to make it easier to fight COVID did not have any lower expected shortage. And that's not really surprising. procurement takes quite a long time. You need to build out the space, and you may need to work with suppliers to get you beds and other types of things. So the states, when we look at the states that don't have con laws, and we see that they have so much greater capacity, some of that capacity was built over decades.
Right.
So it's my hope that, however, that in pointing out that they had to get rid of these laws or ease them or suspend them to make it easier for people to fight COVID, that's essentially an admission of failure, that, okay, we do not do a very good job of assessing your community's need. And this is standing in the way of something that access to care, which is something that pretty much everybody agrees is a good thing.
Well, part of the executive order today was to talk about telehealth and to try to get the telehealth restrictions broadened overall and as a long-term effect. So maybe that can be part of what we do with con laws as well.
Right.
Next step is that's something that is an overall thing, because telehealth was such a big deal with this pandemic, and con laws needs to be part of, while it's state by state. Let's continue the deregulation of things, because we've seen what the impact is.
Yeah, that's right. And it's part of a pattern, at the same time that, of course, people are seeing a pretty significant exercise of state power in terms of telling us to stay in our homes and wear masks and all that. There's also been over 600 deregulations at the federal and state level, everything from easing con laws to easing home delivery of alcohol. And so I think this is a really good time for legislators to take a second look at a lot of these rules and say, do they really make sense? If they don't make sense during a pandemic, maybe they don't make sense in regular times either.
Right. Do we have any more questions? We've had a lot of duplication about COVID and about, we focus a lot on our students talk about the certificate of need, and that's been a big issue recently. We've had a number of events in private discussions on con, so it's been interesting. Dr. Bryan talked a lot about it in rural areas, so it was good to have you following up with her.
And by the way, it's interesting, when you talk to legislators from rural areas, many of them are very scared to get rid of con laws because they have been convinced by the providers that in rural communities need con laws more than ever. And it's a odd idea that a restriction on supply would somehow increase quantity supplied, but many of them have been convinced that they need this in order to protect them.
Well, I was happy that you spoke about about charity and how that was it's such a big focus in a number of communities. I spoke with people from North Carolina, where it's such a big issue.
That's right.
And that's always the focus. It's always the focus that in the smaller towns, in the smaller communities, if you get rid of con laws completely, then hospitals won't have that ability. If there's too much competition, then they won't be able to the pricing will be out of control, and they can't, for people that can't afford it, they'll be out. Hospitals won't be able to provide the pricing to them, the free care.
Yeah, so there's a couple of aspects to this. So one is really, it's a very convoluted story. The idea here is, okay, we want to provide free or reduced care to those who are either underinsured or uninsured, or otherwise might find it difficult to pay. So in order to help that person, we'll call him Peter, we're going to give a monopoly to Paul in the hopes that he will then charge a higher price to Mary when she walks through the door. She's well insured, and then maybe somehow transfer that greater profits back to Peter. It's a very convoluted, Rube Goldberg type of system. So no wonder it doesn't work. No wonder we find that there's zero evidence of greater charity care in con states relative to non-con states. Another aspect of it, I think, though, is that, again, it's sort of a convoluted story about the the relationship between restrictions on supply and ultimate supply. The basic story is somehow we need to give a monopoly so that these firms can make a high enough profit that they will exist, because only by limiting the entry of new people will, I guess maybe if we allow entry of new people, then maybe the whole market will disappear. Well, that just doesn't work. We've never seen that in any other market where competition leads to such a state that there's no firms in an industry. Limiting competition has a very consistent effect on markets in that it reduces the quantity of services supplied.
Somebody asked about, they read about restrictions on mental health care and how con laws are providing severe restrictions on mental health care. Can you talk about that a little bit?
Yeah, so if you go to mercatus.org, you can actually click on some of our con research and see which states regulate psychiatric services or services for those with intellectual disabilities. And so off the top of my head, I'd say it's probably around 20 states or so. And we're going to be updating that research, by the way, in the next few weeks with new data. But to me, this is something that anytime I talk to legislators, I say, if there's any room for a reform, this has got to be it. A con law that restricts access to care for the most vulnerable among us, that just seems like a no-brainer to repeal. Same thing for drug rehabilitation centers. Yeah. About 20 states restrict con laws, restrict the introduction of new drug rehabilitation centers. In this day and age, it just seems extremely backward to think that we have too much health care, mental health care, and too much drug rehabilitation care. That's just not at all in sync with the reality that people are experiencing.
Yeah, absolutely.
If I have, if you can indulge me for one more minute, I'll tell one quick story. So, as you kind of alluded to, I've thrown a lot of numbers at you, and I'll admit, as an economist, I've probably thrown too many numbers. Sometimes the human brain wraps its mind around, is able to think of an anecdote a lot better than a number. So I just want to leave you with a story, just to show you how these things operate in the real effect. So a few years ago, there's a facility in Southwest Virginia called Lewis Gale Healthcare, and they applied for a con for a neonatal intensive care unit, and they were denied. The next year they applied again, and they were denied. The following year, a mother showed up at Lewis Gale. She was in premature labor, and there were complications, and they were worried about the baby's viability. And they don't have a neonatal intensive care unit, so they couldn't care for the mother or baby. So they asked the nearest facility, I believe it was in Roanoke, to send over an ambulance. They actually didn't have a con for an ambulance, so they couldn't even send the baby on their own. They had to ask for an ambulance to come to them. And the baby passed away before the ambulance showed up. Now, it's virtually impossible to know whether the baby would have survived if it had the benefit of a neonatal intensive care unit. But here's the remarkable thing. The following year, Lewis Gale applied for a con saying, look, here's the story. Here's what happened. Here is somebody in our community that said that they needed care. They came to us needing care. And the regulator still said that's not sufficient evidence that your community needs this service. So, I can throw as many numbers at you as, you want. But to me, that kind of a story that shows exactly what happens in terms of the human cost of this is really the best way to illustrate what's going on here.
So with that, if nobody has any more questions, my contact information will be at the end of the screen. If anybody does have any follow-up questions, you can also look at mercatus.org, and you can get all of Matt's contact information there as well, and you can reach him directly. You can reach out to me, and I can put you into contact with him. Go to Mercatus and read all of their wonderful. I'll put up a link in the comments section of all of our places. Please go and read some of their wonderful information. We often link to some of their research in our newsletters, which we're so thankful to partner with you and to share your information. Matt Mitchell, thank you so much for joining us today. Always a pleasure to speak with you and with your colleagues at Mercatus. We're thankful for everything that you guys do. So.
Thank you so much, Rebecca. It's been a pleasure chatting with you, and thanks to you for all you do to increase the quality, access, and freedom of people trying to seek care in the United States. I really appreciate it.
Thank you, everyone, and we will be back with a fee-for-care podiatrist on the 20th, so look out for that invite. So thank you all very much, and we will talk to you later.
I hope you enjoyed today's edition of the Benjamin Rush Institute's Virtual Events series. To learn more about our educational programs and events just like the Virtual Events series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's Virtual Events series.